Imagine you're in a pediatric ward and an infant suddenly turns completely blue, just gasping for air.
Right, which is completely terrifying.
Oh, absolutely. Your human instinct might be to just panic, maybe run to grab an oxygen mask or, hit the code blue button.
Totally natural reaction.
Right. But the actual immediate first step to saving that baby's life, folding them in half, just literally bending their knees right up to their chest.
It sounds so crazy when you say it out loud like that.
It really does. But welcome to today's custom-tailored deep dive. If you're tuning in today, you are the learner. We know you're constantly hungry for knowledge, but, well, you also value your time.
Exactly. And our mission today is super specific. We're providing a high-yield, engaging review designed specifically for nursing students prepping for the ATI RN Pediatric Nursing Proctored exam.
The big one.
Yeah, the big one. We're looking exclusively at the heavy hitters from the ATI textbook. Specifically, Chapter 20, which is cardiovascular disorders, and Chapter 21, hematologic disorders.
Okay, let's unpack this, because usually when we think about studying pediatric cardio and hematology, there's this, overwhelming expectation of rote memorization.
Oh, for sure.
It feels incredibly intimidating. You're staring at these endless lists of defects and lab values and medication parameters. It just looks like a massive, impenetrable wall of medical jargon.
It's the absolute definition of information overload. Students so often try to memorize, every single symptom for every single disease.
Which is impossible.
Right. Not only is it impossible, but it's frankly exhausting. And it doesn't even help you when a test question throws a scenario at you that you haven't memorized word for word.
Right. But here's our promise to you today. If we stop just trying to memorize the symptoms and start looking at the why behind them.
The actual physical mechanics.
Yes, the actual physical mechanics of the body, you won't just be memorizing facts, you'll actually understand the mechanics of pediatric nursing.
I love that approach so much because when you start connecting the dots mechanically, the clinical picture just makes perfect sense.
It really does click.
Yeah, and more importantly, you start naturally spotting those specific physiological patterns that test makers absolutely love to evaluate.
So let's start right at the center of it all with congenital heart defects. I like to think of this as, the plumbing of the heart.
That's a great way to put it.
We're looking at structural abnormalities that are present at birth and how they alter the physical flow and pressure of blood inside the chest.
The best way to understand these defects is to remember one simple rule of physics. Fluid always flows from an area of high pressure to an area of low pressure.
Makes total sense.
Right. In a perfectly normal heart, the left side, which is responsible for pumping blood to the entire body, operates at a much, much higher pressure than the right side.
Because the right side just has to pump blood right next door to the lungs.
Precisely.
The left ventricle has to push blood all the way up to your brain and all the way down to your toes, so it has to be the powerhouse.
Exactly. So when we talk about defects that cause what we call left to right shunting, we're talking about structural holes in the heart. These holes let that high pressure blood from the left side shoot back over to the low pressure right side. This category includes ventricular septal defect, or VSD.
Right.
Atrial septal defect, ASD.
Right.
And patent ductus arteriosus, PDA.
Because of that massive pressure difference, the blood takes the path of least resistance, right?
Yeah, exactly.
Instead of going out to the body where it belongs, it takes a U-turn through that hole, goes back to the right side, and shoots right back into the lungs.
And that mechanism is your high-yield takeaway. You are essentially overloading the lungs with extra blood volume.
Oh, wow.
Yeah. This increased pulmonary blood flow is exactly why these infants present with manifestations of heart failure. You'll see tachypnea, or rapid breathing, because the lungs are flooded.
They're just struggling to exchange gas.
Right. You'll also see tachycardia, because the heart is working complete overtime to compensate for the blood that keeps taking that U-turn.
And I guess that explains the murmurs, too.
Oh, absolutely. You hear those loud, harsh murmurs because you literally have turbulent fluid shooting through a hole where it really shouldn't be.
Okay, so that's left to right. But then we have the flip side of the coin, right? Defects that cause right to left shunting, where pulmonary blood flow is actually decreased.
Yes. And the heavy hitter here for exams is tetralogy of Fallot.
I always think of tetralogy of Fallot as a 4-part perfect storm of plumbing errors.
It's a highly accurate way to visualize it. You have 4 distinct defects occurring at the exact same time. First, you have pulmonary stenosis, which is a severe narrowing of the valve leading to the lungs.
Okay, blocked exit.
Yep. Second, a ventricular septal defect, so there's a hole between the ventricles. Third, an overriding aorta.
Meaning the main exit vessel is kind of shifted over the hole.
You got it. And fourth, right ventricular hypertrophy.
Yeah.
Because the right side is getting overworked trying to push past that narrow pulmonary valve.
So because the normal exit to the lungs is blocked by that severe stenosis, the unoxygenated blue blood is forced through the VSD over to the left side.
Right, and out to the rest of the body, which means the body isn't getting nearly enough oxygen.
That sounds incredibly dangerous.
It is. And that leads to a massive red flag for tetralogy of Fallot. Hypercyanotic episodes, which are commonly referred to on the floor as TET spells.
Oh, TET spells.
Yeah. During a TET spell, the infant experiences acute cyanosis and hypoxia. It's a severe, life-threatening drop in tissue oxygenation.
Which brings us back to that scenario I mentioned right at the start of our deep dive. If a baby starts turning blue with a TET spell, my first instinct is to grab oxygen.
Which makes sense, logically.
Right. But the textbook says the priority physical nursing action is to immediately place the infant in the knee-chest position, folding them in half. It seems so counterintuitive.
It really does, until you look at the plumbing again. By grabbing the baby's legs and bending their knees tightly to their chest, you're intentionally kinking their femoral arteries in their legs.
Oh, I see.
Yeah, this massively increases the systemic vascular resistance, basically the pressure in the lower body.
Wow. Okay, so because you just artificially spiked the pressure on the left side of the heart by blocking off the legs, it suddenly becomes way harder for the blood to bypass the lungs.
Exactly.
You're physically forcing the blood to take the correct route past the stenosis and into the pulmonary artery to get oxygenated.
You're literally using the baby's own body mechanics to temporarily fix the pressure gradient inside their heart.
That is just incredible. And speaking of kinking blood vessels, that perfectly bridges us into obstructive defects, specifically coarctation of the aorta.
Yes, a very important one.
I like to compare this one to a kinked garden hose.
That's the perfect analogy for it, honestly. The aorta is the main superhighway carrying oxygenated blood out to the body. In coarctation, there is a stricture, or narrowing, usually right near the ductus arteriosus.
Right, so if you've got a tight kink in a running garden hose, the pressure builds up insanely high right before the kink, right? And then it's just a weak, sad little trickle after the kink.
Exactly. What's fascinating here is how one simple structural narrowing creates two completely different, totally contradictory clinical pictures in the exact same patient.
Because the blood vessels that feed the head and arms branch off the aorta before the narrowing.
Yes.
So the upper body gets all of that backed up high pressure.
That is the crucial detail to write down for your exams. When you assess an infant with coarctation of the aorta, you're going to find bounding pulses and dangerously elevated blood pressure in the upper extremities.
But the lower body is starved.
Right. Because the blood flow is totally obstructed trying to get to the lower body, you're going to find cool skin, weak or completely absent femoral pulses, and noticeably low blood pressure in the lower extremities.
You don't have to memorize a random list of symptoms if you just close your eyes and visualize that kinked hose.
Exactly.
So we have all these plumbing issues inside a baby's chest. Obviously, we can't just leave it like that. How do we actually get in there and fix it? Or at least, how do nurses prep these kids for interventions and manage the resulting heart failure?
A major diagnostic and interventional tool you'll be tested on is cardiac catheterization.
Okay.
Preoperatively, there are two massive safety checks you need to know. First, you must thoroughly assess for allergies to iodine and shellfish.
Right, because the radiopaque contrast dye they inject into the bloodstream during the procedure is typically iodine-based.
Yeah, an allergy means you're looking at potential anaphylaxis right there on the table.
Yikes.
Second, the child must be strictly NPO for 4 to 6 hours prior to the procedure. The dye can cause nausea, and if they're sedated, vomiting could lead to fatal aspiration.
That makes a lot of sense.
Now, post-op is where the heavy, intensive nursing assessments come in. You're keeping the child flat and maintaining the affected extremity, usually the leg where they went into the femoral artery, in a straight position for 4 to 8 hours.
Let me make sure I'm thinking about this correctly, though. If there's bleeding at that femoral insertion site, human instinct says to press your hand directly on top of the bleeding.
Sure, that's what we usually do.
Just cover the visible hole in the skin, right? But the text says you apply continuous pressure 1 inch above the catheter entry site. Why aren't we pressing on the actual wound?
Because the puncture in the skin isn't actually in the exact same spot as the puncture in the blood vessel.
Oh, it's a tunnel.
Yep.
The catheter enters the skin, but it travels up the leg slightly underneath the tissue before it finally pierces the vessel wall.
You've got it. Applying pressure 1 inch above, localizes the physical pressure directly over the actual vessel puncture, which is what actually stops the internal hemorrhage.
That is so smart.
Yeah, pressing on the skin hole does absolutely nothing to stop the artery from bleeding underneath.
That's such a brilliant, testable distinction. Now, let's talk about managing the heart failure that usually accompanies these defects. The
Okay.
clinical manifestations fall into three buckets, right? Impaired myocardial function, like tachycardia and pallor, pulmonary congestion, like tachypnea and severe retractions, and systemic venous congestion.
Which causes fluid backup, resulting in hepatomegaly, an enlarged liver, and peripheral edema.
Got it.
When caring for an infant with heart failure, your primary nursing goal, dictating every action, is to conserve their energy. The heart is already failing. We absolutely cannot make it work any harder than it's already struggling to do.
Which means we change how they eat. The text says to feed the infant every 3 hours when rested.
Right.
You don't wait for them to wake up crying and starving because crying burns precious, massive amounts of energy, and you hold them at a 45-degree angle.
Yes, the semi-Fowler's position maximizes chest expansion. By sitting them up, gravity pulls the diaphragm down, making it mechanically easier for their flooded lungs to expand and breathe while they expend energy eating.
And we definitely can't talk about pediatric heart failure without putting a massive spotlight on digoxin.
Oh, absolutely not.
It improves myocardial contractility. It basically forces the failing heart muscle to pump stronger and more efficiently.
This raises an important question regarding safe administration, because digoxin has a notoriously narrow therapeutic window. The line between a helpful dose and a toxic dose is razor thin.
Very thin.
You must listen to the apical pulse for a full minute prior to giving it. You're going to hold digoxin if an infant's pulse is less than 90 beats per minute, or if a child's pulse is less than 70 beats per minute.
And you've got to watch like a hawk for toxicity. The major red flag here for digoxin toxicity is vomiting, which is honestly really tricky because babies spit up all the time.
It is tricky, but here's the physiology. Digoxin toxicity actually stimulates the chemoreceptor trigger zone in the brainstem.
Oh, wow, so it's neurological.
Yes, it's not just a mild stomach bug. It's a profound neurological reaction to the medication level being dangerously high. If a baby on digoxin is experiencing actual vomiting, poor feeding, or bradycardia, you have to suspect toxicity immediately and hold the dose.
Okay, so we've covered the structural issues you're born with. Let's shift gears and look at acquired cardiovascular diseases, things that attack the cardiovascular system during childhood. First up is Kawasaki disease.
Kawasaki disease is an acute systemic vasculitis. That means widespread, intense inflammation of the blood vessels all throughout the body.
Sounds painful.
It is. It typically resolves in less than 8 weeks, but it has very distinct, highly testable phases. The acute phase is characterized by a high fever that is completely unresponsive to antipyretics like Tylenol or Motrin.
Just won't break.
Right. The child will have red eyes without any drainage and a classic strawberry tongue.
And a strawberry tongue isn't just a slightly red tongue. The intense vascular inflammation actually causes the normal coating of the tongue to slow off.
Yeah, it's pretty severe.
It exposes the inflamed, swollen blood vessels underneath. It literally looks like the bumpy, bright red skin of a strawberry.
Exactly. Then you move into the subacute phase. This is when the fever finally goes down, but you start seeing keeling skin around the nails, palms, and soles of the feet.
Ouch.
Yeah, this happens because that intense vascular inflammation actually damaged the epidermal layer from the inside out. And finally, the convalescent phase, where the visible clinical signs resolve, but their lab values are still altered.
Now, the treatment for Kawasaki is 5-E gamma globulin and high-dose aspirin. But wait a minute, aspirin.
I know where you're going with this.
Everything in nursing school drills into you that giving aspirin to children with a viral fever is a massive no-no because it triggers Rey syndrome, which causes brain swelling and liver damage.
That's an excellent catch, and it's exactly why test makers love this topic.
Yeah.
We normally never give salicylates to children.
Right.
However, Kawasaki disease is the rare, highly testable exception. Aspirin is standard protocol here because the severe inflammation of the blood vessels carries a massive, life-threatening risk of coronary artery aneurysms.
So it's protecting the heart.
Yes, the aspirin acts as a powerful anti-inflammatory and an antiplatelet to prevent catastrophic cardiac damage.
So the immediate benefit of protecting the heart from rupturing entirely outweighs the statistical risk of Rey syndrome. Got it. The other acquired disease we need to touch on is rheumatic fever.
Rheumatic fever is an inflammatory disease that occurs as a reaction to a group A beta-hemolytic streptococcus infection. Simply put, it happens a few weeks after an untreated or partially treated case of strep throat.
And the go-to lab test here is the anti-streptolysin O, or ASO, titer. It's the most reliable blood test to prove there was a recent strep infection. But what does this actually look like clinically?
You're looking for erythema marginatum, which is a distinct rash, tender subcutaneous nodules over bony prominences, and chorea, which presents as sudden, involuntary, purposeless muscle movements.
And the mechanism behind this is wild. It's molecular mimicry. The child's immune system creates antibodies to fight the strep throat.
Right.
But those antibodies get confused. They look at the proteins on the heart valves, the joints, and the basal ganglia in the brain, and they say, hey, this looks a lot like that strep bacteria.
So they start attacking the child's own healthy tissue.
Yes, that's why you see the jerking movements of chorea. It's temporary autoimmune damage to the brain.
Spot on. Now let's leave the heart and the vessels themselves and look at the actual blood flowing through them.
Okay.
How do abnormalities in red blood cells and clotting factors present in pediatric patients?
Okay, let's do it.
Let's start with sickle cell anemia.
In sickle cell anemia, the normal adult hemoglobin, hemoglobin A, is replaced by an abnormal sickle hemoglobin, hemoglobin S.
And when these abnormal cells are subjected to stress, like being deprived of oxygen or during dehydration, they physically change shape. They go from being smooth, flexible, round discs to rigid, sticky crescent or sickle shapes.
I always picture a sickle cell vaso-occlusive crisis, like a massive traffic jam in a narrow alleyway.
Oh, that's a good one.
Normal red blood cells are like motorcycles. They can just zip right through tight spaces. But when they sickle, they turn into giant, rigid delivery trucks. They get stuck, they physically clump together, and they completely block the alley.
And when blood flow is blocked, the tissue downstream is totally starved of oxygen. That severe tissue ischemia causes the hallmark symptom of a vaso-occlusive crisis, which is agonizing, debilitating pain.
The other type of crisis you have to know is a sequestration crisis. This is where the sickled blood pools excessively, usually getting trapped inside the spleen or the liver.
Because so much of the child's circulating blood volume is suddenly trapped inside an organ, the child rapidly develops hypovolemia.
They just don't have enough blood circulating.
Right. They don't have enough blood left in their actual vessels, which can quickly progress to hypovolemic shock and cardiovascular collapse. It's a true medical emergency.
So for interventions during a sickle cell crisis, what are the priorities? Promoting rest to decrease the body's overall oxygen demand.
Yes.
Administering intense hydration, both IV and oral. If you pump them full of fluids, you're essentially diluting the blood, spreading out those stuck delivery trucks, and helping to flush out that traffic jam.
Exactly.
And of course, pain management. But it has to be on a schedule, not just PRN or as needed. You have to stay ahead of the pain loop.
For long-term management, there's a vital screening tool regarding stroke prevention. Because those sickled cells can easily clump and occlude vessels in the brain, children ages 2 to 16 with sickle cell disease must have a transcranial Doppler test performed annually to detect their risk of stroke.
Moving right along to the other hematologic heavyweight, hemophilia. This is a bleeding disorder where the child is genetically missing a specific clotting factor in the coagulation cascade.
It frequently presents with hamarthrosis, which is bleeding directly into the joint spaces like the knees or elbows.
When you look at the lab values for a child with hemophilia, you'll see that the activated partial thromboplastin time, the APTT, is significantly prolonged.
However, and test makers love this carch, their platelet count and their prothrombin time, or PT, will be completely normal. The issue isn't the platelets, it's a missing protein in the clotting cascade.
So what does this all mean for the nurse who's actually providing care at the bedside?
It dictates every physical interaction you have with the patient. You want to avoid any unnecessary skin punctures. If you absolutely need a blood sample, use a venipuncture.
Wait, really? A needle in the vein over a tiny finger stick?
It seems counterintuitive, I know. But a clean needle stick in a vein actually bleeds less and is easier to hold pressure on than a jagged finger or heel stick.
Okay, that makes sense.
You never administer intramuscular injections, subcutaneous only, and absolutely no aspirin, which would further inhibit their platelets.
And if they do have a bleeding episode in a joint, you follow the classic RICE-E protocol. Rest, ice, compression, and elevation.
Right.
But I noticed a crucial detail in the text regarding range of motion for these joints. Active range of motion is encouraged after the bleeding is controlled to preserve joint function, but passive range of motion is strictly contraindicated during an acute bleeding episode.
That's right. Can you deduce why passive motion is so dangerous here?
Well, if the joint space is actively filling with blood, it's already under immense pressure.
Yes.
If the nurse is the one grabbing the arm and forcing the joint to move, which is passive motion, they could easily push it too far and inadvertently tear the joint capsule that's already swollen tight with blood.
Exactly. You must let the child completely control the movement themselves, active motion, so they can stop immediately if the pressure or pain becomes too much.
We're wrapping up today with two incredibly common everyday blood issues that show up constantly on exams and in real-life pediatric clinics. First up is iron deficiency anemia.
This is the most prevalent anemia worldwide. We see it peak in two very specific pediatric populations. First, adolescents, due to their rapid growth spurts, generally poor diets, and the onset of menses in females.
Okay.
Second, infants, specifically right around the time they transition from iron-rich formula or breast milk over to cow's milk.
And cow's milk is basically the enemy of iron. Not only is it a very poor source of iron itself, but it actually irritates the infant's GI tract, causing chronic microbleeding that further depletes their iron stores.
Yes. So if a child's prescribed an iron supplement, there are strict administration rules you need to teach the parents. You give iron 1 hour before or 2 hours after milk or antacids.
Because calcium blocks it.
Exactly. Calcium severely binds to and decreases iron absorption. But giving it with vitamin C, like a glass of orange juice, creates an acidic environment that significantly increases absorption.
And if the prescription is for a liquid iron supplement, always tell them to use a straw. If the kid just drinks it straight out of a cup, it's going to permanently stain their teeth.
Yes, very important.
And while we're on the topic of patient education, you have to warn the parents about the diaper changes.
Oral iron supplements will turn the child's stool a dark terry green color. It's just unabsorbed iron reacting with hydrogen sulfide in the GI tract.
But parents freak out.
Oh, parents will absolutely panic and think it's a GI bleed if they aren't warned ahead of time. But the nurse needs to proactively reassure them that this is a completely expected, harmless finding that actually indicates the dose is adequate.
Finally, let's talk about epistaxis, or simply nosebleeds. This seems so incredibly basic, but people get it wrong in real life all the time.
The trap here is positioning. When a child has a nosebleed, you have them sit up and tilt their head slightly forward.
But wait, usually when someone gets a nosebleed on the playground or at school, the very first thing the adults do is tell them to tilt their head back and pinch the bony bunch of their nose. Why are we leaning them forward?
Tilting the head back is totally outdated and genuinely dangerous. It causes all of that blood to flow down the back of the throat.
Which makes them sick.
Very sick. Blood in the stomach is highly emetic, so it leads to severe nausea and vomiting. And worse, it creates a massive risk for choking and aspiration. Tilting forward lets the blood drain out safely. You then apply continuous pressure by pinching the soft lower part of the nose, not the hard bony bridge, for at least 10 solid minutes.
Just 10 solid minutes of pressure, head forward. It's so simple, but getting that wrong on an exam is such an easy trap to fall into because of what we see in movies.
It's a classic distractor answer, designed to test if you know the actual safe physiology.
All right, let's pull all of this together. Our mission today was to give you the exact tools you need to crush your ATI Pediatric Nursing Proctored exam.
And I think we covered a lot of ground.
We really did. We skipped the endless lists of bullet points and focused entirely on the mechanics. By understanding the physics of the heart's plumbing, the neurological triggers of digoxin toxicity, the molecular mimicry of rheumatic fever, and the vascular damage of Kawasaki disease, the nursing interventions just become intuitive.
You don't have to memorize them on a flashcard because you actually understand how the machine works.
Exactly.
If we connect this to the bigger picture, it's incredibly crucial to remember the human element behind all of these mechanics.
What do you mean by that?
Well, consider the profound psychological impact on a developing child who requires lifelong, highly restrictive routines. Imagine a toddler with hemophilia who is just learning to walk and run, but soon has to grapple with the understanding that they can never play contact sports with their friends.
That's heartbreaking.
Or an adolescent with sickle cell anemia who is desperately trying to fit in with their peers, but is constantly managing chronic, agonizing pain and frequent, isolating hospitalizations. The source material we review today strictly outlines the clinical interventions, but it inherently raises a much deeper question.
Which is?
How does the constant threat of a physiological crisis permanently alter the psychosocial identity of a child? It's a stark reminder that as a nurse, you are never just treating a defective valve or a mutated cell. You are treating a growing, feeling human being whose entire world is shaped by these diagnoses.
That is an incredibly powerful thought. It completely changes the perspective of walking into a pediatric patient's room. You, the listener, you're not just taking an exam to get a grade. You're preparing to walk with these kids through some of the hardest parts of their lives. We wish you the absolute best of luck on your ATI Proctored exam. You've got this. Just remember, when you feel overwhelmed by the muddy waters of a complex diagnosis, go back to the plumbing. Think about the physical mechanics. If you understand the machine, you'll know exactly how to care for the human.